This talk is going to be slightly lighter than the previous ones, but nonetheless, it's our bread and butter. It's about dialysis, and it's something we've been doing for quite a while now. But do we have much science behind what type of dialysis and when we deliver it? I'm not sure that we do. This, I hope you'll recognize, is a crystal ball. It's a tool for looking into the future. It's to see what the patient's outcome might be following our intervention. And unfortunately, it's a tool that we're not very well trained in how to use. I do a lot of pre-dialysis clinics. I see a lot of patients with low GFRs. And their million-dollar question to me is, when will I start dialysis? And I always nearly say, well, it's a bit of a crystal ball gazing exercise. But the patient has plans, and they think that dialysis means the end of everything, and it's a very high-impact decision for them when they should start. We've heard about guidelines and trials and other tools yesterday to help us give good care. But what other tools do we have at our disposal? Is the crystal ball one of them? This is a plane crash. This is the crash lander. This is what we are trying to avoid. Often I can't say to the patient exactly when they'll start dialysis, but what I do say to them is what we don't want is inadequate preparation for a smooth landing. We want to avoid the crash lander wherever possible. The plane without enough fuel, the plane misses the runway, the plane that lands in the field, the plane that does not have any of the support staff it needs from the control tower and the emergency services. What do we arrive at? An emergency situation, emergency services required, fatalities, injuries, and poor outcomes. We also be mindful that we don't want to land the plane just before the runway. The runway is a finite area. Land too soon, increased risk of mortality, morbidity because of excess fuel on board, perhaps. Land too late, and this is the outcome. So we need the cooperation from the passenger, the pilot, the air traffic control. It's a multidisciplinary approach, and we need safe conditions. But where is this sweet spot? Where is the runway? Where is too soon, and where is too late? And why is it important? Well, timing is everything. It doesn't just make a good story and a good analogy to starting dialysis. It's a high-risk period starting dialysis. The mortality rate for CKD stage 5 is quite high, 20 per 100 patient years, and in the first 3 months after dialysis, up to 50 per 100 years. This study is quite nice. It's from America, but what it is it includes all patients who started on dialysis. If you're in America, it may not be coded at all for the first 90 days because you may not be eligible for Medicare support. This was over 300,000 incident patients who were followed for 52 weeks using the electronic billing system with over 30 million dialysis sessions. And you can see here, this is the relative risk of mortality with the time on dialysis. And you can see how it peaks here and is really quite high and then tails off. This is hospitalization, showing a similar figure, but without the peak. So dialysis is a high-risk strategy. And it's high risk in the early stages of dialysis, which is maybe where we're going to start people. We have better rates, however, in this sub-analysis with people with fistulas and, interestingly, people on peritoneal dialysis. So what tools do we have at our disposal to land this plane? I don't think we have this many. We may have tried to gather this many tools, but we just don't have them. We don't even have the opportunity of simulation either, which I'll come to later, can only be done with statistical models. So to reduce the mortality in the early period and to avoid the crash land is our goal. But sometimes, as we all know, crash landing is inevitable. So what's the first tool that we have? Well, it's the GFR or estimated GFR. And in fact, these guidelines were the first ever guidelines produced by K. Doki in 1997. So what was initially a limited resource for dialysis for the few became, through nothing more than conventional wisdom, led to these guidelines, which suggested that we should start with a creatinine clearance of 9 to 14 mils per minute by MDRD. So even then, though, there were at least 3 caveats: that the patient was fine, eating well, gaining weight, stable weight, that the protein adequate intake, and that actually, number 3, complete absence of clinical signs or symptoms attributable to anemia. So even the conventional wisdom stating that we should be doing this resulted in a caveat of this, which is probably where we're going to end up. There was limited understanding, really, and this was largely reliant on just the GFR. Then in 2002, things were further complicated slightly by the MDRD equation and our well-recognized definition of the stages of chronic kidney disease. The classification used the MDRD, that was the whole point of their study, and this MDRD equation was later criticized, as you'll all know, as an underestimate of kidney function when compared with measured renal function. And in subsequent years, there have been various iterations of the GFR and the eGFR measurement. In any case, what it did result in was this definition of kidney failure. Kidney failure is defined as either a level of GFR of less than 15, which is accompanied in most cases with symptoms of uremia, or the initiation of renal replacement therapy for the treatment of complications of a decreased eGFR. This was based on what is called conventional wisdom, nothing more, nothing less. And take note of this phrase, is arbitrary and may need to be modified based on advances. So even though we talked about guidelines yesterday and what they may or may not mean for the individual, but here's a guideline which states that this definition is arbitrary. The European guidelines followed suit directly and reinforced this earlier dialysis of less than 15 mils per minute. It also stated that diabetics may benefit from an earlier start, and this is based on serum albumin and how that predicts your prognosis. And to ensure that everybody should start by the time they get to 6, and really we should start between 8 and 10 because we know that there is a run-in. So what did this lead to? This conventional wisdom led to the guidelines and led to a surge of dialysis patients starting at high GFRs. Now, this is data from America. This is 1995. This is 2013. And this is a peak in 2010. So these guidelines came in around about here. There was already an upward trend for the first set of guidelines, a second set of guidelines, till we reached this point. Part of this tail off may be due to transplantation, or what I'm going to speak about next. It's confirmed here that the biggest increase in the number of patients on dialysis was in this lower GFR, this higher GFR of 15 mils per minute, estimated GFR. This is this increase here, and this is the 10 to 14. Again, this is American data, which has its own caveats. So was this a good thing? Should we be starting all these patients on dialysis with GFRs of over 10? But was this a good thing at all? The dangers of dialysis I have described to you, the tension between harm and good, and the chances of survival at any given starting GFR are a complex balance of how the patient tolerates uremia to how the patient tolerates dialysis. And the pivot point can be different within each patient or even within the time that each patient is with you in the clinic, it may slip one way or the other. You've seen the increase in mortality, but there are also the other risks related to access, psychosocial, isolation, depression we heard about, with no more holidays, and more importantly, the loss of residual function, which we know is associated with better outcomes, the preservation of residual function. It's this balance, this pivotal point that we don't fully understand, and I'm afraid I'm not going to give you an answer. But is there harm to starting earlier? This is an observational study from 2011. It's a meta-analysis of cohort studies showing hazard ratio mortality, all-cause mortality. And it's using the GFR at the time of the initiation of dialysis to predict mortality. I've only taken some of this, but what is interesting, no difference between PD and HD when you start. What they had was the good fortune that they had a lot, with the meta-analysis, that they had a lot of data and they had variability in how the residual renal function was measured, or the function at the start of dialysis, be it GFR, eGFR, and creatinine clearance. And what they noted was that those with the creatinine clearance had a reduced mortality predictor, so a lower GFR, creatinine clearance at the time of dialysis was a better predictor of mortality versus the estimated GFR. So what does this tell us? This might tell us that creatinine clearance is a better predictor of when a patient might need to start dialysis, where that pivot tips towards benefit rather than risk. This is a similar kind of information. It's a prospective study from Holland, which looks at the incident dialysis patients until death or transplant. It's in a paper entitled MDRD Formula Does Not Reflect the GFR in End-Stage Kidney Disease. So what we see here is that when the patients all had a measured creatinine clearance at the time and were followed up to the point of death or transplantation, and these are three groups. So this is when they started with low renal function is the dotted line, medium is the grey line, and high, this is referring to the GFR at the point of dialysis. And if I recall high, I think this was around about 15. And you can see that the patients with the highest GFR had the worst survival rate. And this is at the point of initiation of dialysis. So in summary, initiation on dialysis is dangerous and a risky period for the patient. The guidance on initiation is generally based on numbers and conventional wisdom. And in fact, more may not be better, more could be worse, and that the eGFR is not a useful tool in isolation. So we move on to perhaps the only case-controlled trial looking at the benefit of early versus late initiation of dialysis. Around 2,000 patients were entered, but unfortunately, only about 800 took part in the end, and this was in Australia and New Zealand. The early dialysis group was 10 to 14 mils per minute, and the late dialysis group was initiation at 4 to 7 mils per minute. So this is the time to dialysis. So the reason this study was criticized is that there was a lot of overlap. And I think that reflects real life, that you have 400 patients you say are going to start late and 400 early. But you know, you do the clinics, things don't often work out the way you hope they do. And in fact, that's why I'm here today to talk to you. In the end, the difference in renal function between the early and late was only 2.2 mils, but there was at least a 6 months difference in the start time. What about mortality? All-cause mortality, there was no difference, also with quality of life. And because this was a case-control trial with well-matched groups and coexisting specific conditions, such as cardiovascular disease and infection, this did not tip the balance in either way for either group in terms of mortality. So there were a lot of criticisms of that study, and observational studies tried to account for the difference. This is actually another study which is looking at serum albumin in patients who are starting dialysis. This is the fittest group with the highest serum albumin, and you can see this is the low GFR start, this is the high GFR start, and that there is a dose response, that those who are the fittest according to this analysis with the highest albumin suffer the worst in terms of dialysis. This is another study. Again, this is a statistical retrospective cohort study which attempted to exclude the lead time bias and selection bias in the other studies. And again, that we can see that early dialysis is not necessarily beneficial and in fact possibly harmful. What about subgroups? We don't see them on the young or the modality or the race or the ethnicity, but there is no compelling evidence so far for us to make a decision. And in fact, we arrive at a new set of guidelines. I won't read them all to you, but safe to say there is confusion. Yes, start at 15, maybe wait till 6. No, don't take any notice of the GFR, wait for the clinical symptoms. It's all a bit of a muddle, which again is why I'm here today to try and talk to you about the benefits of when we should start dialysis. Are there any at any point in time? So this Captain Sully managed to save this plane, and I think we can do the same. He managed to get his passengers out safely. So despite the limitations, I think we can do good for our patients. And how can we ensure that we land on the runway without all of the fuss? Well, it's back to the old-fashioned things that we've talked about a lot. It's about understanding the patient, about the burden of dialysis for that patient, about the symptoms that the patient has, about what's important to the patient. And it's about residual function. And we heard yesterday about incremental dialysis as well. So again, one size does not fit all. And it's, I'm afraid, not possible to tell you when you should start your patient on dialysis. We hope to have some more information shortly from the EQUAL study, looking at better able to quantify uremic symptoms. But again, I think there'll be no substitution for the patient and their multidisciplinary team and the run-up and the care of the patient in the clinic. To set a few examples I've got here from our actual clinic to illustrate what I've just told you and how impossible it is to come up with an individual guideline. So this patient, patient A, is female, estimated GFR of 19, creatinine 290, but in hospital, in and out with heart failure, has a kidney transplant. Should we be starting this patient on dialysis? Possibly, according to some of the guidelines, possibly not the others. This is a 54-age male. We actually see a lot of these in our clinic. The estimated GFR is 4, the creatinine is 1,000, but the patient is perfectly happy. What are you talking about, doctor? I feel perfectly well. And maybe that patient has a point based on the data I've just shown you. This patient is a bilateral amputee. What does that mean for the creatinine? Again, GFR 9, allowing for this. No, doctor, I'm not going to start dialysis. And here we have the 88-year-old male, eGFR 6, creatinine 809. Well, an independent. Should we ever be starting this patient on dialysis? So this is what we would like to see. We would like to see a nice approach, a clear runway, daylight, and lots of support in terms of supporting the patient and supporting our own decision-making, helped by the people who know the patient. And to quote Dr. Osler again, who was quoted yesterday, we can either be the good physician and treat the condition, or we can be the great physician and treat the patient. Thank you for your time.
My talk, as you said, that during the time we formed the Kidney Foundation, the healthcare situation in 2003, the population was only 136 million, but the healthcare budget was given only 0.9% of the GDP, one of the lowest in South Asian region. And the priority areas of the government are population control, mother and child health, and control of infectious disease. And there is a least priority given to the treatment of kidney disease and kidney failure. So, Kidney Foundation, when it is formed in 2003, the situation was not very good, but our aim was to offering treatment with state-of-the-art at affordable price in clinical nephrology, dialysis, and transplantation, and to conduct academic activities and research, and providing training for doctors, nurses, technologists, and paramedical staffs. In 2003, we have only $1,000 with hand, and with this $1,000, we take a brave decision and hire a house in capital city Dhaka with 7 staffs and 6 dialysis machines on loan, which are refurbished dialysis machine, and a very small lab and outpatient department. The consultation fee was only $1, and dialysis fee per patient per dialysis was $10, which is 1/3 of the profit hospital in Bangladesh. At the start, in October 2003, we have only 16 dialysis, but at the end of year, we found that more than 380 dialysis being performed in that hospital. Specialist consultation service provided in October is started in 21 patients, and at the end of it has increased to 250 patients. And similarly, lab service was only 147, and at the end of the year is more than 500. And this becomes very popular with that community level, and they are demanding more and more. And at the same time, we go for the community and CSR from the banks and also other philanthropists of those areas and in Dhaka. So in 2005, we shipped our dialysis beds from 6 to 15 in number. OPD and lab service was strengthened, and indoor activities started with only 30 beds. And fortunately, we get a very brave decision to start kidney transplantation in 2006 with that hired house. And we also started the screening program to detect kidney disease among the 5,000 people in the rural, urban, and disadvantaged population healthcare professional in Dhaka. And this is the first time we understand that there are about 16% of chronic kidney disease in Bangladesh and 12% with healthcare professional, and disadvantaged population is about 16%. Fortunately, in 2008, we got a own land by the government with 2 acres, and we shifted from there, but there is no money at hand. So again, go and everywhere, particularly to the bank and corporate bodies, to give us donation so that we can build this hospital. And those who helps to build the hospital, we have put their name or the banker's name so that they can be helpful for us. So dialysis beds was further increased from 15 to 60, indoor beds increased from 30 to 70, outpatient department was increased to 150 to 200 patients per day, and lab facility was very much strengthened, and we started a paperless hospital and telemedicine as well. In 2013, we obtained the Joel D. Capel Award from International Federation of Kidney Foundation, and they recognized that with exceptional contribution to people who have kidney disease and kidney failure, preferably the very poor and very poorest of the patient. In 2018, we further increased the beds from 150 to 300 beds, now look like this with 8 floors. An outpatient department of Kidney Foundation shows that there are many patients has increased. The specialist consultation fee remained the same with $2.5 to $4 US. Dialysis and treatment transplantation fee is only less than $1, and total number of patients consulted in OPT was nearly 600,000 if we calculate from October 24 to September 2024 within this 20 years time. So you can see the gradual increase of the number of patients in outpatient department, more than 62,000 a year. Laboratory facilities also increase tremendously with a modern diagnostic facility at all levels, but all are given 30% discount in all patients. All types of investigation, including tissue typing, serology, PCR, even PTH, vitamin D3, HBV DNA, HCV RNA, CMV DNA, and many more, it can be easily found for which patient require this. Microlesion imaging service, CT scan, ultrasonography, Doppler study, renal angiogram started. And you can see that the laboratory facilities and the number of tests is performed is more than 45,000. And if when we even discount the 30% discount to all patients, we have calculated that we have given 4 million people to help within these years. Emergency facilities is strengthened. The dialysis facilities is over there. ICU facilities is recently done by ICU doctors, and there is 8-bedded of ICU nephrology. And indoor facilities is strengthened again to 300 beds, into the 110 beds of dialysis unit in one umbrella. Facilities for free beds, more than 30%, are available for poor patients. Dialysis fee either reduced or free depending on the financial condition of the patient. There are regular teaching around by the assistant professor and the assistant professor, and indoor treatment is highly recommended by the all patients. There are 6,000 patients admitted in 2024, and most of the patients are acute and chronic glomerulonephritis, nephrotic syndrome, diabetic kidney disease, hypertensive kidney disease, urological disease, stone disease, and other problems, which is about 45%. Unfortunately, end-stage kidney disease is about 37.5%, and AKI in 2024 are 17% in our hospital. In dialysis facilities, the cost is so low. It is in private hospital, it is 3 times more, and in our hospital, it is only $13 US, where in private hospital, it varies from 30 to 58 US. So, if we calculate the money we given to the patient's facility is US 28 million taka as compared to profit centers. The patient about 110 umbrella dialysis is huge dialysis, and more than 800 patients go for dialysis every day in 3 shifts. The number of patients, we calculated 775 patients, male outnumber that of female, mean age is 64 years. Twice weekly dialysis is about 78% and thrice weekly dialysis is 22%. We calculated the residual kidney function, and those who are more than 500 ml urine in 24 hours, we just go for twice weekly dialysis until and unless there is a comorbid condition foreseemed for shortness of breath or ischemic heart disease. CAPD facility is done by a nephrologist, catheter inserted by nephrologist, and CAPD started in 2011 with 10 patient number, and in 2024-28 in number, number is dropped due to COVID infection. Still, we have got more than 610 patients at now. The total number of the patient, mean age is more than 60 years. Male outnumber that of female. There is more comorbid in CAPD patient with ischemic heart disease and also cardiac function and cerebrovascular disease. Outcome of CAPD, as you can see, that most of the patients are doing CAPD, but there is some converted to hemodialysis and also left to follow up and diet. About 111 patients and transplanted in 7 patients, and this death patient is not due to peritonitis, but possibly due to heart attack and other condition, and they lost to follow-up because the enormous expenditure occur in CAPD in our country, because the Baxter is every year they are increasing the CAPD fluid, and so it is not possible to cope with the patient. So survival is only 3 years for 60%. Transfacility Kidney Foundation is the most viable alternative for hemodialysis, but the number of patients is not very much increasing. We have a very good transplant sector in Kidney Foundation Hospital, and every Saturday we follow the transplant patient, and we charge about 0.84, less than $1 for their investigation cost, reduced to 30%, and for poor patient it's completely free, and the charges taken is 1/3 that of the profit centers. And we do some transplantation in foreign patients, particularly in African countries. We do ABO, incompatible kidney transplant, first up, only performed in Kidney Foundation Hospital. And in 2023, we have successfully performed deceased donor kidney transplantation with a 24 years old lady, and both the recipients are female. And in 2024, another deceased donor transplantation in Kidney Foundation Hospital, along with the help of the BSM Medical University. So during the COVID infection, again, the number of transplantation has decreased, and we now cope it up, and we are starting again in full swing. Of the 613 patients, the mean age was 31 years only. Male is outnumbered about 78%. Female is 130%. That indicates there is a more gender disparity in transplantation, and this is possibly in the Asian countries same as well. Mothers come forward for the donate, but the father never comes forward. Wife donate more than husband, and this is the more painful situation in kidney transplant. So survival is 93% first year and 50% for 15 years, and our survival is similar to that of other Asian countries. The cost is enormously low in Kidney Foundation. only 159 million US dollar, but in profit center, it is 2/3 more as compared to Kidney Foundation Hospital. Intervention, jugular venous catheter occurs every day, native kidney biopsy done every day, transplant kidney biopsy done when it is necessary. AVF construction is done by ourselves. And if we consider the cost of Kidney Foundation, it is 1/3 low than that of profit center as well. So if we modalities of Kidney Foundation, you can see that 65% are doing hemodialysis, 23% transplant, 10% CAPD. If we compare this with the national level, where 99% are hemodialysis, 91%, 6% is CAPD, 6% is transplant, and 2% is CAPD, indicating that we have some prevalence rate is more important for our condition than that of the other centers. So the benefit offered to the patient with hemodialysis, transplant, and investigation is US $33 million go to the pocket of the patient, but not with us. We also only give benefit. In service provided in 2023-24 is more than almost 6,000 patients. OPD consultants is 92,000. Number of kidney transplant 24. Number of patients on maintenance hemodialysis is more than 1,100. Number of patients on hemodialysis, and AVP should have performed on 1,726. Jugular catheter performed 1,233. Kidney biopsy performed 242. CAPD done 28 in 1 year. So donation we received every time, every year, and also the Zakat fund for the Muslims. All Zakat fund goes to the hemodialysis and transplantation, and for donation we use also to the transplantation. Academic activities is unique in Kidney Foundation. We have MOU with Royal London Hospital from 2017, and here Professor Magdi Yaqub is over there. He is working dedicated for academic activities and also doing other courses, and they research fellow. They also maintain the research fellows all together, and most of them training is performed over there. We are doing annual conventional scientific seminar from 2004, even today. Weekly seminar, weekly transplant meeting, death review, histopathological meeting with Royal London Hospital, and journal meeting every 2 weeks. Research and publication, there is 38 research publication from 2016 to 2021. Total number of abstracts 41. Ongoing research protocol is 20. PhD obtained by 2 previously, and now ongoing PhD is doing by one another. That is with Royal London Hospital. Renal Sister Center program with ISN started from 2017, and Director General of Health Service, and they are also doing research with us and other people. These are 3 days training for doctors, nurses, paramedics, all for the community clinics, and to run the community clinics at the remote places. And this is also medical officers providing lecture in continued medical education program, and also the renal biopsy meeting with Royal London Hospital every month by Zoom methods. And we also SRC training research fellowship from the Royal London Hospital, lecture of renal nursing in Bangladesh. Only we give the training for about a year, and this is the 5th batch we are passing. We also give the practical training in hemodialysis to them for the renal nurses. Diploma giving ceremony for renal nurses, this is the last 5 years. And We have the training of renal nutrition with other hospitals, that is other universities, and is an excellent collaboration done by the most of the universities as well. We have obtained ISN Sharia Award in 2024 because of graduation from ISN Sister Renal Center program and earned recognition as an ISN Regional Training Center in 2024. Hopefully, we can give training to our center as well as to South Asian Center as well. There are branches, 4 more branches in Kidney Foundation Hospital, and all of them has academic activities. And my last slide is about the summary. Kidney Foundation providing health care to kidney patients at affordable price without compromising the quality. It is also contributed to education and training for doctors, nurses, paramedics, and promoting research. Foundation is planning to expand its facilities throughout the country.
Topic for my discussion is the diseased donor organ transplantation program. What are the barriers, challenges, and the recent breakthrough and triumphs which we have achieved in the state of Tamil Nadu. So in India, the diseased donor transplantation program is kind of governed and formulated by NOTO, an national organization, NOTO, under which regional organizations, ROTOs, come in, and each state has got SOTO, State Organ and Tissue Transplantation Organization. In Tamil Nadu's SOTO is known as TransTan, the Transplant Authority of Tamil Nadu, for which I am currently the member secretary, kind of in charge of the entire program in its entirety. We all know the diseased donor organ transplantation, the need for it is felt more than ever before. Why do I say so? A quick glimpse of the dismal situation, alarming situation of the CKD epidemic, or I would call it as a CKD pandemic across the globe. A rough estimate of about 850 millions of people are afflicted with CKD world over. And the worst fear is that 1/3 of such patients are living in 2 countries alone, that is India and China. And how about Tamil Nadu? In the state of Tamil Nadu, for the first of its kind, the Institute of Madras in Nephrology, Madras Medical College, along with the Department of Public Health, we conducted a statewide CKD prevalence survey. A lot of information it gave in. We adopted the randomized cluster sampling method. It was a huge exercise. The entire state was divided into 177 clusters, and randomization technique was adopted. And these are the highlights of it. 32% of our patients were hypertensive, and 18% diabetics, and 60% were overweight or pre-obese or obese. And this is the most important finding, that is 8.4% of Tamil Nadu adults do have CKD stage 3 and above. So in CKD stage 5, the projected number is about 2.1 lakhs. And in Tamil Nadu, CKD is the 5th most common cause for mortality. Okay. And coming to etiology of our survey, about 9.6% of the patients had diabetes, and 22% had hypertension, and 11% had both hypertension and diabetes. Surprisingly, about 53% of them, they were neither diabetics nor hypertensives. Most of them probably have CKDU. That is another big problem. And to add on to my assumption, there was a publication from JIPMA, there is a Pondicherry. As you can see here, there is a density, the dense clustering of CKDUs. 51.7% of the total CKD patients of that big tertiary institution, it was CKDU. So what do I say so? Now, there is a double whammy Tamil Nadu is facing. On the one hand, the metabolic diseases like hypertension, diabetes, and obesity contributing for CKD. On the other hand, the CKDU problem. We do have a lot of CKD hotspots. Probably because of the hot and humid climate, the heat stress and the chemicals in our life, and the dangerous levels of environmental pollution. So it's a double whammy. There is huge CKD crisis we are facing. So we resort to hemodialysis. Thanks to the Prime Minister's National Dialysis Program and the Chief Minister's comprehensive health insurance program of Tamil Nadu. Dialysis therapy is accessible to a common man. It is provided free of charges. So there is huge expansion of dialysis services, but unfortunately, as it has been highlighted by the previous speaker, I would say hemodialysis is the most eco-unfriendly therapy. Why do I say so? The current data, about 3 million patients are on dialysis world over. More than 330 billion liters of clean water is used annually, and 1.3 billion tons of waste is generated. So this is not the real solution for the problem. So we had to go for transplant. Definitely kidney transplantation constitutes an integral component of the so-called green nephrology, right? But there is a flip side of the living donor kidney transplant. As it has been pointed out by Professor Harun Rashid, there is gross gender injustice in living donor kidney transplant. More than 60% of the donors are women. And more than 60% of the recipients are men. So that's what is. And again, there are a lot of concerns about the long-term safety of living kidney donors. That is altogether a different topic. I will not touch on that. So definitely, we need to promote the disease donor organ transplantation more and more and more. What is the current scenario in India? India is not a country. It is a subcontinent by itself. 1/6 of the entire mankind is in India. But this is the data. The organ transplantation Indian data, the total number of donors for the year 2023, it is not just kidney, I'm just talking about other organs as well, 16,000 plus. The living donors were 15,000 plus. The disease donors was only 1,099 for the entire country in India. So that is the current situation. But even though I say so, there has been a gradual improvement in terms of the disease donations in India. As you can see here in this graph, for the past 1 decade, from 2013, there were only 340 donors. And in 2023, it has gone up to 1,099. And this is the first ever time in India, the number of disease donors crossed 1,000. That is 1,099. How about the kidney donations? The total number of kidney transplants that took place in India in 2023 was 13,426. But out of which, only 8.2% came from deceased donors. So this is a dismal number, right? And in India, there's a gross disparity and differences in different states, how the disease donation program has percolated. The states which have been shown in green, that is the southern part of India and western part of India, the program is fairly well expanded. But the other parts of the country, the red ones, not even initiated. So this kind of a gross difference is there. The state where I'm coming from, the Tamil Nadu and adjoining states of Andhra Pradesh and Telangana, we are doing fairly well. Well, in this situation, I was given the mandate by the government of Tamil Nadu to take over this program and with a mandate of improving the program. When I took over, I just analyzed. I found out it is not just a program which can just be run by the doctors, nephrologists or technocrats, not just by the policymakers. So it is a grand program which involves, in a very complex, a very nuanced program like this, it involves the contribution and the beautiful collaboration of different domains. The 5 important domains are the political will. There's a very strong political will in India. Our Honorable Prime Minister himself has mentioned about disease donation at least 3 times in his personal Man Ki Baat program to the nation. And most of the states also, there's a very strong political will to take up this program. And bureaucracy is equally motivated. Media is greatly supportive. So there are 2 important domains which need to be addressed. Number 1, the public. We have to get more public acceptance for donation. And number 2, the most important domain, the technocrats, meaning the experts, the medical and paramedical staff. Right. So with these in mind, we kind of brought in certain innovative initiatives. Number 1, we wanted to pay tributes to the deceased donor in the most befitting way in every institution. We initiated the honor walk for the deceased donor. The first honor was started in Madras Medical College a year ago. I was part of it. And subsequently, according honors for the deceased donors by the government of Tamil Nadu at the residence of the deceased donor by district collector or a top official of the district. And then more inclusivity. Instead of keeping the program, the capital city-centric or major city-centric and major hospital-centric, I thought, the key to success is that spreading the program across. And then to allay the fears and anxiety of the medical and paramedical staff, we need to kind of conduct a structured reappraisal and training for faculty. So this is a picture depicting the honor walk, what we do in a very grand way. In every institution it happens. More than 200 people. We stand in two rows and, in a motorized vehicle, the mortal remains after the organ retrieval is given a ceremonial kind of a tribute. And this has had a huge impact on the psyche of the society. And the most important step is that a government order issued by the government of Tamil Nadu that the honors will be accorded by the district collector at the residence of the donor before the final rites. So far, 300 state honors have been accorded. This impacted very substantially on the psyche of the society. The public acceptance has enormously increased. As you can see here, a young collector taking a wreath in a very remote village of Tamil Nadu in Tiruvannamalai. And this is a 250th honor was accorded by our Honorable Health Minister himself. Honorable Health Minister itself. This happened in Madras Medical College. And this is the latest one which happened yesterday and so on. So now the program has expanded beyond the realms of just medical field. The bureaucracy and politicians have entered into the program of Tamil Nadu. So what has happened? A high acceptance rate for organ donation. Within 3 months after these initiatives, more than 8,000 pledges came in. And now the acceptance rate in the major institution like Madras Medical College for organ donation is more than 80% with just one counseling itself. With the second round of counseling, the acceptance rate is more than 90%. There are instances now patients themselves come forward to donate. Okay. Fine. Then most important next step is that there are many hospitals which do not have facility for doing a transplant, but they have an ICU with more than 25 beds and an intensivist and so on. So what the government of Tamil Nadu did is that it passed a GO announcing them as non-organ transplant retrieval centers. They have to identify brain death and then certify brain death, and the organs can be retrieved and utilized in other centers. So with this move, there are only 13 government centers in Tamil Nadu which do kidney transplantation. 13 government medical college hospitals, they do kidney transplant. There are 34 medical college hospitals. All the other things, so it was like this. Only these districts depicted in green were involved in the program initially, and now the entire state is involved in the program. 13 hospitals perform transplant. All the other hospital, medical college hospitals, they identify brain death, organ retrieval is happening. So the result is that the entire state is involved. The inclusivity of the program, all the length and breadth of the state in the program, I feel this is an important step that took us forward. So as you can see here, there are 22 government institutions which donate organs, which identify brain death, and 33 private hospitals. Totally 55 centers in state of Tamil Nadu. Last year, they donated organs. Fine. Next step is that there are many, what is required? I thought, I just understood, conducted a survey kind of, why there is an inertia among the medical professionals. Very simple reasons, some anxiety, some fear of a little bit of doubts about certifying brain death and so on. So to allay all those things, we conducted a very structured reappraisal, reorientation program for the faculty of all other medical colleges. It was conducted jointly by Transton and Madras Medical College, a 2.5 days program. Kind of training them in every aspect of the diseased organ donation, transplantation, particularly the brainstem dysfunction identification, brain death certification process, and maintenance of the deceased donor. We identified each of the problems. For instance, maintenance of the deceased donor, the major problems are hypernatremia, hypokalemia, hyperglycemia, and acidosis. For each and every aspect of this, we devised a protocol, and that has been uniformly spread out. And once they attend this program and go back to their respective centers, they go back to their respective centers and certify more and more. Okay, there are certain other initiatives also. The monthly review of the performance by official level at all levels. Even the Honorable Health Minister conducts a review of all the medical college hospitals' performance twice a year. So that's what is happening. And a personal appreciation, whenever there is a donation takes place, an appreciation reaches the hospital. With these measures, I could show about 30% improvement in the performance. This is July 23 to June 24, a 30% improvement in the performance within few months after taking these initiatives. So this is the current data of Tamil Nadu. So this year, from January 1st, 253, by the time I put slide 251, yesterday 2 donations took place. It was 253 in 11 months, not even 11 months now. So this is the highest number in less than a year for one state in the country of India ever since the program started. So the national average is 0.7 per million population, the donation rate. In 2023, in Tamil Nadu, performance is 2.12 PMP, and 2024, still another 40 days are there. It has already crossed 3 per million population. Fine. So the disease donation Tamil Nadu data, from 2008 onwards, total number of donors 2037. In 2024 itself, there are 251 donations took place, out of which in 2024 itself, already 421 kidney transplants from deceased donors took place. So I would suggest the action plan to be adopted in any center or country where the program has to be taken up. Identify a nodal officer for every institution, form a core committee, a grief counselor and transplant coordinator, devise a very robust institute protocols, and there should be representation from every ICU of the hospital. Create a WhatsApp group for a seamless flow of information among all the stakeholders. Everyday data sharing on brainstem dysfunction. Weekly review by core committee and monthly review by head of the institution. In our state, the health minister himself reviews twice a year. And before saying that, before finishing, I'll say that again and again, we need to have a clear-cut impression that this program cannot be accomplished by a single person or a single department or a single institution. It has to be a kind of a collective efforts of all the stakeholders. There is no I here. It is actually we. So I would like to end the talk with a quote by Edward McRae. Donation gives an ability to the final moments. It's not just a pulling at a plug, a removal of machines. It is an act of extending the gift of life, a giving back, a passing on. It's a way to affirm life, to shout a note of victory into the ugly face of death. Thank you so much.